I'm Lin Ying. Thank you so much for the opportunity here to present our latest work on a real-world evidence study on treatments for opioid use disorder. So we just completed the study on or had the initial preliminary results from our own database, and we're currently looking for data partners. So if you're interested, feel free to reach out. Opioid is a public health crisis. Over 2.7 million people had opioid use disorder. It causes over 100,000 drug overdose deaths in the recent years, and this trend is still increasing. And about 70% of those deaths are involved opioids. So opioids is still the major driver of drug overdose death in the United States. Well, this is a public health crisis, meaning a lot of people are affected. There are actually, it's actually treatable. So there are 3 FDA-approved medications for treating opioid use disorder. They're effective for lowering the risk of OUD and reducing opioid craving or opioid overdose. And these are based on multiple randomized controlled trial results. So those 3 drugs are called methadone, buprenorphine, and naltrexone. So in this study, we focus on methadone and buprenorphine, mainly just because naltrexone is a relatively new drug, and there are not that many patients who are prescribed with that. And so both methadone and buprenorphine are agonists, meaning that they bind to the opioid receptor to block the withdrawing symptoms and opioid craving. Although there are randomized trial results to show that they both are effective, and I think methadone is more effective than buprenorphine in those trials. However, I think there's still a gap in real-world evidence in terms of their effectiveness in the real world, because they have very different availability and also dosing frequency. So methadone is only can be prescribed and administered in methadone clinics that are certified clinics by a special opioid treatment program, and patients need to go in daily to get the drug, the medication. Buprenorphine relatively is under a less stringent regulation, so any prescriber with certain qualifications can prescribe this medication. So, and because of a methadone is only administered in methadone clinic, and because we're using electronic health records data from an academic medical center, so once the patient leaves the hospital, we don't really know whether they go to a methadone clinic to continue the treatment. And because of that, our study design is really an intent to treat. We saw that the doctors recommended methadone to the patients while they were in our system, and that is basically the time 0 for this target code. So to just summarize what I just said, our goal is to estimating the comparative effectiveness of methadone versus buprenorphine in reducing opioid-related acute care use, meaning emergency department or inpatient visits among OUD patients. Our question is that is methadone or buprenorphine more effective? And this is a retrospective comparative intent to treat cohort study. So study design, we have a target arm, we have a comparator arm, and there are 3 variations of outcome. So the acute care use is defined as inpatient ER or inpatient later ER visits with a diagnosis of either the first outcomes like OUD, any OUD diagnosis or opioid overdose. And we also look at OUD and opioid overdose separately. This shows the target and comparator cohort definition. Basically, we look at the exposure to, take methadone as an example. We look at a patient who initial exposure to methadone during an ER or inpatient visit, and we require at least one condition occurrence of OUD or opioid overdose prior to the drug exposure. Patient who are 16 or older, and the follow-up continues until either end of observation period or a drug exposure of an alternative medication. And the cohort definition is similar for buprenorphine. For the outcome cohort, we have these three variations. Taking the more general one as an example, the outcome is defined as an inpatient or ER visit. And during that visit, the patient has to have at least one opioid use disorder or overdose diagnosis so that we know it's an opioid-related acute care use. The data we use in the study come from the BJC Healthcare Network, which is a healthcare provider network in the greater St. Louis area that includes 14 hospitals and about 2 million patients. And this data is transformed to OMAP common data model. And this is the standard workflow of a Odyssey study, population level effect estimation. We create a cohort using Atlas. We run cohort diagnostics, and we use the cohort method package to build a propensity score model, do a bunch of checks, build a Cox proportional hazards model, and look at the hazards ratio. So here are the preliminary results from our database. First, this is a cohort characterization by calendar year. On the left is the methadone cohort. On the right is the buprenorphine cohort. On the left, we saw that the use of methadone started to increase around 2014 and peaked at 15. And according to my clinical collaborator, Dr. Liz, this well aligns with when the hospital started the opioid consult clinic. So, and that's, a lot of patients get referred to the clinic and they got the treatment recommendations to be on those treatments. Although the buprenorphine becomes more popular than methadone in the recent years. And my understanding, one of the reasons at least is because it's just easier to prescribe and works well. This is a demographics breakdown. Most of the patients in our cohort are patients in their 20s and 30s. And we have about 70% patients whose race is recorded as white and about 30% as Black or African American. Here's a medical history patients. The most common ones are hypertensive disorder, depressive disorder, viral hepatitis C, some respiratory disease are more or less aligned with our understanding of the baseline conditions of these patients. And they also tend to have cardiovascular disease and various tumors. And here are the most common medications used by patients in our study. Psycholeptics, like medications used to control seizure, some anti-inflammatory drugs, and also antidepressants, because these patients also have a high risk of having mental disease. Oh, and I forgot to mention, we showed that before and after matching for all these covariates, and after matching, most of the covariates are balanced with a 0.1 cutoff. This shows the incidence rate of the three outcomes. For the three outcomes, we have more patients on buprenorphine than methadone, and after calculating the percent years, there's a higher incidence rate for buprenorphine than methadone across the three outcomes. Not sure how significant this difference is, but this is the incident rate based on person. But the effect estimation method is pretty standard. We used large-scale propensity score and then do one-to-one propensity score matching. We adjust our pre-treatment covariates and use a Cox model to model the risk. So here show the effect on the general outcome, meaning either OUD or overdose. So basically, after matching, we about 1,600 patients remain in the cohort after matching, and the hazard ratio is 0.96, and it's not a significant, indicating that if we look at this outcome altogether, there's not a significant. The drugs perform basically about the same. And when we look at opioid overdose only, well, the Kaplan curve doesn't look that much different for the two, but the hazard ratio just below the upper bound, just below 1. So technically, it's statistically significant, meaning methadone reduces the acute care use, opioid-related acute care use. Yeah, and these are the hazard ratio for the 3 outcomes. We only observe a significant effect on opioid overdose. Some discussions, conclusions. Basically, we're looking for data partners. So if you're interested, feel free to reach out. And we're working on the GitHub repo, and a study protocol has been uploaded. And if you're interested, you can take a look, and we can go from there. And a big shout out to my analyst, Ruo Chong, who joined my team 3 months ago, and he basically implemented the study, and everything, really all the credits goes to him. And also my collaborator, Dr. David Liss, who's an emergency medicine doc here at WashU, who actually runs medical toxicology lab here, and who are basically the doctors. He and his colleagues are the doctors seeing those patients with OUD. And my other collaborators, thank you so much.